know that the diagnosis of multiple system atrophy can be difficult to make and often occurs at a tertiary care center. Yet when patients go home, their primary care providers are on the front line of their care. So we sought to bridge the gap between tertiary care providers and patients' local care providers in caring for patients with multiple system atrophy to try and ensure that they can have the best quality of life possible. Hello, I'm Dr. Elizabeth Kuhn, a neurologist at Mayo Clinic in Rochester, Minnesota, specializing in movement and autonomic disorders. Thank you for the opportunity to talk about our recent paper, My Treatment Approach in Multiple System Atrophy, published in Mayo Clinic Proceedings. I'm grateful to have the opportunity to work with my movement disorders mentor, Dr. Eric Alskog, on this work. Dr. Alskog has extensive experience caring for patients with multiple system atrophy. First, I'm going to talk about multiple system atrophy. Then I'm going to talk about different treatment approaches that we have found to be helpful. And then lastly, I'm going to talk about multidisciplinary care models and how this can also be done through collaborating with primary care physicians. Now, multiple system atrophy is a neurodegenerative disorder. It progresses at varying paces and is characterized by both motor and autonomic failure. The motor impairment is characterized by Parkinsonism, which looks like Parkinson's disease, but typically does not respond as well to the classic medications used to treat it, or can be predominantly cerebellar, or cerebellar ataxia, termed MSA-C. This form has much more imbalance in coordination and affects fine motor, as well as gait, walking difficulties, and can lead to falls. In terms of the autonomic failure, this classically presents with orthostatic hypotension, which is a drop in blood pressure upon standing. The blood pressure can get so low so that patients can have syncopal episodes and are at risk for injury associated with those. Also, we know that with that orthostatic hypotension, though, patients may have supine hypertension, meaning when they're lying flat, their blood pressure is too high. So this can create unique treatment challenges. Genitourinary failure is often commonly seen in multiple system atrophy, and this can present with sexual dysfunction in men or women, and then urinary frequency, urgency, and incontinence. Constipation can be problematic, as well as another autonomic failure, anhidrosis, or a reduction in sweating and difficulty with thermal regulation. In addition to the autonomic and movement components to multiple system atrophy, we can see sleep disorders, frequently dream enactment behavior, characteristic of REM sleep behavior disorder, is problematic for patients. And stridor is a classic finding as well. This is impaired mobility of the vocal cords that can lead to a type sound heard by patients' bed partners, and sometimes during the day. In addition to the motor, autonomic, and sleep dysfunction, we can see other issues occurring in patients with multiple system atrophy as well. This includes depression, anxiety, and about half of MSA patients also demonstrate pain, which can take a variety of different courses. With this complex set of symptoms, often the treatment can be very difficult or complex. But there are some simple things that we can do to try and optimize care for patients with MSA and really get that best quality of life. From the motor standpoint, for Parkinsonism, we tend to recommend carbidopa-levodopa, or replacing dopamine. This can help with patients' mobility, and help with some of the stiffness and sometimes pain that can go along with multiple system atrophy. We do watch out for excessive dyskinesias, or extra movements, that can occur with treatment with levodopa. And even though the response isn't as good as what we tend to see in Parkinson's disease, patients often can have some benefit, meaning it's an important part of the treatment in these patients. Now, cerebellar ataxia really doesn't have a pharmacologic treatment, but that's where partnering with physical therapy can be really helpful to maintain mobility and really trying to reduce fall risk as much as possible. Now, the autonomic features in multiple system atrophy can take a lot of different courses. As for treatment for orthostatic hypotension, in the paper we outline a lot of non-pharmacologic measures. So increasing fluid status and specifically doing something called cold water fluid boluses. We also talk about pharmacologic ways to kind of do this volume expansion, and fludrocortisone is one medication that can be helpful. Mitodrin is a vasoconstrictive agent that can be helpful in patients with multiple system atrophy. Now, mitodrin can also lead to that supine hypertension, so care needs to be taken so that patients do not lie flat for 4 hours after taking mitodrin. So non-pharmacologically, having the head of the bed elevated can be helpful, and having patients check blood pressures while lying flat before bedtime is also helpful to guide our management. We tend to use this multidisciplinary care model because you can see with these different symptom manifestations and all the necessary treatments, a lot of different providers are often involved in the care, including physical medicine and rehabilitation, physical therapy, occupational therapy, speech therapy, sleep medicine, urology, and sometimes gastroenterology as well. We have found palliative medicine can be very helpful in caring for these patients both early on after diagnosis, throughout the disease, and as we transition towards more end-of-life cares. Now, we have put together an MSA multidisciplinary clinic at Rochester and have really partnered with palliative medicine as well as these other subspecialties. What we hope to see on a more nationwide basis is multiple system atrophy centers of excellence. So following in other neurodegenerative disorder care models as well. And with this, we really seek to care for both the patient to improve the quality of life, but also try and support the caregiver and families as they're going through this disease as well.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.